Welcome to Health System CIO's interview with Edwina Bhaskaran, Chief Clinical Systems and Informatics Officer with the Mayo Clinic. I'm Anthony Guerra, founder and editor-in-chief. Edwina, thanks for joining me today.
Thank you, Anthony.
All right, great. If you want to start off by telling us a little bit about your organization and your role.
Sure, happy to. So, good morning. And again, thank you for the opportunity to speak with you today. I'm honored to be part of Mayo Clinic, one of the leaders in healthcare that's been transforming lives for over a century. At the heart of everything we do is our primary value: the needs of the patient come first. This guiding principle isn't just a motto, it's a commitment that shapes our culture. Every year, Mayo Clinic serves over 1.2 million patients from all 50 states and over 135 countries, offering care that is collaborative, compassionate, and cutting edge. Our integrated group practice brings together experts from every medical specialty, and we ensure each patient receives the best possible outcomes. Our humble beginnings started in Rochester, Minnesota, where our primary campus is, but we also have major campuses in Jacksonville, Florida, and in Arizona and Scottsdale. We also serve over 70 community-based facilities across our Mayo Clinic health system. I'm really excited to be here today and share a little bit more about what I do. I'm the inaugural Chief Clinical Systems and Informatics Officer for Mayo Clinic. I report up through our practice shield, and my primary focus is really around serving our practice and ensuring the needs of the practice is met in healthcare IT and in the rollout of our clinical systems. From a clinical systems standpoint, our primary clinical systems focus is our EHR, but we have supporting ancillary systems that make up the ecosystem for clinical system as well. So really excited to be here with you today and get this chat started.
All right, very good, Edwina. Thank you. Explain to me the relationship of Mayo with the Mayo Clinic platform. As we mentioned before we get started, Dr. John Halamka, president of Mayo Clinic platform, a wonderful guy, known him for a very long time. Um, just from an entity point of view, is that a separate entity? How's that work?
Yeah, so Mayo Clinic platform, as I'm sure Dr. Halamka shared with you, is a component of our Mayo Clinic ecosystem. So its focus is on how do we make things better for groups, not just within Mayo Clinic, but for the betterment of healthcare globally. And so Dr. Halamka and his team has been partnering with several others to create an ecosystem of collaboration and coordination among other healthcare organizations in terms of contributing to data, as well as serving as an incubator for up and coming companies that are looking to serve other needs. And so it serves from that standpoint. It's a lens that gives us an opportunity to take Mayo Clinic beyond our walls to other organizations and extend kind of our services from that standpoint.
Okay, very good. All right, so I know today we're going to talk about this idea of different types of projects, IT projects, and you've written about this concept you call sticky, which is this idea of projects being successful in terms of use, which is very important. That's sort of a huge theme in the discussions I'm having with everyone over the last 6 months. It's this real focus on use, as opposed to perhaps just implementation and turning things on. People are completely focused on that, as they should be. So that's this idea of sticky. Sticky means use, means uptake. Sticky, the opposite of sticky would be you could have a quote unquote successful implementation, maybe from a technology point of view, where the use really isn't there. And then, we no longer call that success in IT. So your thoughts there, I guess the idea, let's start with the idea of um, you know, this is solving a problem. So the problem is things not sticking. So let's first talk about implementations in general and some of the reasons you think that they don't stick. And then we'll talk about how to make them stick.
Sure. So from a sticky perspective, I think the concept really started as I was thinking through how how does our tools and technologies, how have they evolved? How do they evolve? They actually have a life of their own. So our systems today don't look the same as they did yesterday. And that's because we are in a constant state of carrying and feeding for our tools to make sure that they're keeping up with not only the latest technology advancements, et cetera, but also the needs of our practice. What is the latest evidence? What are the changes that we need to make in terms of formulary and operational processes? So being that visual person, I thought, it's really this almost blob concept. And then the thought of it being sticky is the idea that it's not something that's set in stone. And like lots of technology, there are opportunities for it to evolve, but also when should it retire? So that was really the concept behind where did sticky kind of evolve from. As you mentioned, sticky has various components to it. It's the thought behind it is it needs to be simple, it needs to be timely, it needs to be integrated into workflow. The culture of the organization or said unit or group of units needs to be ready for the change. The tool needs to be knowledgeable in the sense that it needs to be able to tell us about the practice. It needs to provide us data with adoption. And last but not certainly least is yield. We need to make sure that the return is worth the effort for the people by which we're implementing the change, both from a clinical lens, but also from a patient lens.
All right, lots of good stuff there we'll dig into. Just something you said that I found interesting, a little off the topic, but you mentioned you were a visual person. Tell
Mhm.
me what you mean by that.
So, visual in the sense that my notes tend to be drawings. I tend
Okay.
to try and find concepts that are visually something that morphs into from a visualization perspective, then into words. So that's really kind of the genesis of sticky in my mind was it's not something that's concrete. It's not something that's really a framework. It's more of a set framework. It's more of something that's evolving.
So, that's a really interesting idea. And I totally agree with you. Some people, you talk about the way people learn, the way people absorb. And it's interesting when you're in a position of authority or in a position to have people do certain things for you, you can request things in the way you want them, right? You could say, you know what, this doesn't work for me. Give me it this way, give me it that way. Not that you're being arbitrary, but the point is, you know how your brain works. You know how you can absorb information best. So, as you said, I want to draw it out. You're telling them, listening, and I want to draw this out. I want some image here that's going to help me. That's how my mind absorbs things. We're all different. And that makes me think of training, which is a huge issue we're going to get into in the conversation. And this concept I've talked to many people about of providing a variety of different types of training for individuals because everyone learns in a different way. Everyone has a different time restraints, different flexibility, learns in a different way. You might have a user who says, listen, I understand you want to train me up on this. Here's how it's going to work best for me. Here's the timing. Here's how it could be asynchronous, could be synchronous. I want somebody with me at the elbow, or just send me some videos. People are completely different. So, your thoughts around that kind of concept?
Yeah, it's a very timely topic because we are more than ever fighting for people's attention, and so training has always been a while we think about it during initial rollout of technologies, ongoing training, ongoing supplemental information and communication is something that's kind of an afterthought. So, from a training lens perspective, there are definitely different avenues and venues. I appreciate Anthony, what you just said in terms of it needs to meet the learner where they're at, and so there are definite different opportunities that we have. You can do short videos. You can do in classroom training, depending on the individual. You can do peer to peer training, video training. There's all sorts of different avenues, but it comes with a cost. So as we are looking to train in different modes and mechanisms, we have to look at what is that cost to the organization, and it has to meet and return back to that yield. So if it's a change that will yield substantial returns for us, both in terms of patient response, clinical response, in terms of making the clinicians' lives easier, and the effort that it takes to create all of these multiple venues and opportunities for training, we've got to take a look at that also. I've also found that when you are talking to clinicians in particular, there's nothing that is as substantive as a peer-to-peer telling them, hey, I tried this technology and it really works. And let me tell you why this works for me. So I think in all of the training concepts, starting with the why is really important. Why are we making this change? Is this change meant to decrease your workload in some way, shape, or fashion? Is this because we have to do it for regulations, which often sometimes happens? Or is it another operational need? So I think starting with the why, thinking about the different venues, and also making sure you bolster that with some peer-to-peer support is really important.
I really like this concept of cost that you talk about, and sounds like is balance and cost. Usually, this comes up a lot, this idea of balance in terms of risk, sometimes cybersecurity risk, but in general, there's this idea of balancing cost benefit. And you're talking about balancing cost benefit in terms of training, meaning we could spend $1 billion and provide every kind of training under the sun, and we could have at the elbow for everybody, and people run. It's not sustainable. It's too expensive. It doesn't work. So it's that balance of finding. I don't know if you start with the money you have. So you say, this is the money we have for training. This is now let's figure out how to best spend it. Or you figure out, here's what we want to achieve on the training side in terms of number of people trained or options. Now, what does this cost? How do we find the money? What are your thoughts there?
Yeah, I actually think it starts with the problem that we're looking to solve. So we 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 look at, is the technology solving a significant problem? And then to your point, then you look at, here are the resources that I have. Do I need to redirect the resources that I already have, given the substantive nature of this change, given the impact? Do I need to add additional resources to help bolster this training? Or is this a change that perhaps we don't necessarily need to offer multiple modes and venues for training, because it's not that impactful, it's more incremental in nature?
What about this idea? And these are just realities of healthcare. What about this idea of different types of users? An impactful surgeon that is a very well-respected surgeon is going to need a little more attention and get a little more attention than another different like administrative folks or whatnot. So, I mean, to what degree do we do that and customize resources based on, you could even say, job profile. I don't know how you wanna make it as least controversial as possible, but these are the realities. I mean, the star athlete on a team gets a little more leeway sometimes than the run of the mill who could get cut at any minute. So, I mean, there is a group of individuals who need, I don't know, VIP training or something like that. Do you work that into your programs in a
We
way?
do. We do work that in terms of role specific training. I'll also say it's something that we think about in terms of the time that they're in the said system. So oftentimes your most busiest surgeon may not spend as much time in the system because they are delegating that work
Right,
to others. So
right.
I think you have to a certain extent, Anthony, look at the role, the time in the system, and customize it to meet those needs based on kind of your organizational norms.
Excellent. You mentioned a few different sort of elements of change management. It sounds at a certain level, that's what we're talking about. One of the very interesting ideas is um, maximum ability to change or change threshold. Um, Meaning, if we've introduced a lot of change to a group of workers or a unit, like, we don't think they can handle any more change, or they've given feedback to the effect like, we have a day job, guys, IT. We have a day job, and you keep throwing new things out, and maybe some of the things you introduced, there's a whole nother concept here of losing momentum. This concept of, we rolled out a tool that maybe wasn't the best tool in the world. The users didn't like it. Now they're kind of frustrated with IT, and they're like, you know what? That was just a bomb, And now the next time you come around and want to roll something out, they're like, you know what? We're just not up for this. So there's all kinds of issues there around change management and the unit's ability to absorb change, and then how you go about introducing change so that you don't lose momentum, that
Mhm.
you don't waste your opportunity and ruin things for the make things more difficult in the future. What are your thoughts?
Yeah, so change fatigue is real. It's something that I think we deal with on a day-to-day basis, especially in an organization like ours that always is looking for what can we do next. So I think from the concept of change fatigue and managing that with the pace of innovation, there's a couple of things. It's not a perfect science. It's something that you have to balance. First and foremost, you absolutely need to have a clear roadmap of here are the projects that are coming up in the pipeline. And you need to ask the question, Anthony, the question that you just asked, which is around, okay, how much change can our organization tolerate? Which of these changes are mega changes? Which of these changes are perhaps a bit more focused in area? And which of these changes perhaps shouldn't actually be done right away because we have too many other things that are going on. And so I
Right.
think having a clear roadmap of these types of and catalog of these types of changes is important. I think the second thing that I think is also important is to translate that to other non-IT based changes that are happening. So
Oh, yeah.
whether that's a new facility that's coming up, whether that is other
Mhm.
changes that are happening organizationally. I think you have to manage both because it's not just the technical change that our clinicians are often dealing with, it's also the changes that are happening outside of technology. So I think it's definitely an art more than a science, but it starts with asking the question and making sure you have a clear handle on all of the changes that are coming at our end users.
Yeah, I think that's brilliant, and that's something I have not heard mentioned before, but it makes perfect sense, this idea of they may have change coming from many other areas besides IT, and if you just have that IT lens on, even if you're doing it department specific, that's the other best practice someone mentioned to me is, be department specific about what you have going on, because that'll help you make sure you're not overloading a specific department with change. But your point is excellent that you can't only look at the IT change to that department. And I guess that comes with communication
Yes.
with your champions. Do we find this idea of champions? Who are the people in that department that are up for liaising and working with IT and having these conversations? And I don't know if we're talking about formal governance here, but we need to have certain contacts in these departments, people who are IT friendly, change friendly. We don't want them so change friendly that they're not representative of the department as a whole. Um, and then we have those conversations and we could have, hey, what else do you have going on? I mean, what are your thoughts around that?
Yeah, to me, it's less about the governance side of it. It's more on the culture side of it. It's creating that culture that creates safety in speaking up to say, hey, we are getting to a point that this is a tipping point for our department. It's a tipping point for our unit. We're maxed out, and making sure that that channel of communication is open. So to me, it's less about governance, even though that definitely plays a
Right.
part. It's creating that culture where it's okay to be able to speak up and say, we're having a little bit of change fatigue here in this area. What levers can we utilize to perhaps slow this down? Or perhaps we even maybe need to accelerate it because we need to perhaps get over this initial hump. But having that conversation to me is more about setting up that culture versus looking at it from a governance standpoint, which is important, but it's really about establishing that culture.
Yeah, I like that. That's very good. Um, and this helps organizations deal with what can be competing priorities between operational individuals who are delivering care. That's their job, right?
Yep.
They're delivering care, they're doing the best they can. They're usually extremely busy, a frenetic pace they're working at. And yet and you also have IT individuals who are charged with innovation, and they're charged with using their IT budgets to drive change. Those can be slightly conflicting at sometimes if you don't focus on adoption and use. If you focus on adoption and use, you're in less danger, I think, of sort of having, again, too much of a push from IT that operations can't handle. I mean, can you see a dynamic at some organizations if you get this wrong to where those conflicting mandates cause too much change to be driven down into operations?
Yeah, what you're speaking to is when change is happening to individuals versus with them.
Right.
And
Right.
so that I think to an earlier point around getting clinicians involved early and often, I think is really important. So it is again going back to that culture of openness, the dialogue, the art of communication, to be able to say we don't want to have these changes be done to our clinicians. We want them to be part of it. We want to be able to speak to, again, why is this change occurring? What is the impact? What does this mean to them in their day to day? And that takes real development of creating, again, that open culture and that dialogue to say we don't want this technology to be something that's being done to you. We want you to be part of this change, and be able to actually earn that trust to say when you are speaking up, we're going to do something about it.
Right. Right. So, over the years, I've been doing this for a little while, and over the years, you know, 15 years ago, the rollouts failed because users were not involved in the selection process and picking the tools. And then IT, even though that still happens sometimes, which is kind of amazing, and then IT realized, okay, we can't be picking tools. We need to support operations, and we need to, you know, shepherd and encourage and educate and help them make selections. But we want operations to lead these things and to select the tools and all that. So we got that. Um, that's involving users and clinicians on one level. But the piece now, and again, we've touched on this, the piece now that people are realizing is that's still not good enough. Even if you do that, that's not good enough because the education and training you mentioned, just not when a new piece of technology is rolled out, just not when a new employee comes on board. We kind of have those things. We understand those are points where education needs to be rolled out. We can come up with programs. It's the more subtle nuances of perhaps um, important, like an upgrade that's fairly significant, training existing users on that, and then different levels of use, who's using things well, getting metrics from our EHR about what people are struggling with, what individuals are struggling with versus the average time it takes to do something, and then addressing these things and having conversations. So that's like where we are now. What are your thoughts around that sort of evolution and the fact that, training obviously and use and all the different flavors, getting it right? You talked about the balance of resources. So th- there's a lot here. And then I'd like you to touch on how IT changes the game here. And by that, from what I mean is what I've been told is that I think I said IT, but I meant AI. I don't know. AI fundamentally changes. It's not just a new tool piece. It's not just a new application. So your training and education needs is a whole new dynamic here. So what are your thoughts around all that?
Yeah, there's a lot to unpack there,
Yeah.
Anthony. So
Yeah, I know.
let's perhaps maybe start with, AI. I mean, I think as long as we don't repeat some of the mistakes that we've made perhaps earlier on as as a community in terms of digitizing bad processes, I think the opportunity with AI is really significant. And what I mean by that is what I'm seeing is I'm still seeing some of the AI changes be reflective of not necessarily about the way things and processes should be in the future, but rather how do we take something that already exists today and tack on AI on top of it, which might be fine, but it's not necessarily that transformative change that we have the hope for with AI. I think the other thing that you talked a little bit about is this adoption curve and data and metrics, and how does that kind of look over time. Uh, it's an interesting concept because I think there is a couple of things that you can look at. You can look at, of course, from an adoption perspective, are they using the tools? You can get that fairly easy. But the challenge there is to make sure that you're going back on a routine basis and you're making actionable insights as a result of that data. So does the is the change sustained? And if the change isn't sustained, why not? Is there something else that happened over time? Is there a new tool that was released through an upgrade, as you mentioned, that perhaps is changing the workflow so that previous tool isn't necessarily as relevant as it was before? And in that case, I'm a big fan of decommissioning. Love that word. I think we have to be brave enough to say these tools are no longer meeting clinical needs. Let's take it out. Let's take out the clutter, especially in this age as we are looking at new tools like AI, generative AI. Let's also ask that question, which tool can we get rid of when we introduce something new?
I love that. More brilliance. You're knocking it out of the ballpark today. Yeah. So I mean, I never really thought about the fact that an upgrade can degrade a tool,
Mhm.
right? So they could just miss the mark. The vendor just missed the mark. Like you had something that was working for us. You tried to make it better. You didn't. We're moving on. So that's absolutely a very important concept. That ties into sort of application rationalization. Now, the core problem there, it's a worthy idea. Like, I love it. The efficiency aficionado in me loves the idea of application decommissioning. The reality on the ground that I'm told all the time is it's extremely, extremely difficult to
Mhm.
actually get rid of a tool that people are using. Even if there's, let's say, we have three of something, they do the same thing. We want to get rid of one of them or maybe two of them. There are certain users who are using it that you have to take that tool away from. When the rubber hits the road, that's really, really, really hard to actually do. It sounds good on paper. You can do it on a spreadsheet, but people get upset. Everyone hates change. They can't deal with it. Um, because even if something's going to become simpler, the fact that I know how to do it now, there's a cost. It can't just be a little bit better. It's got to be a lot better because change is painful. So it's got to like overcome that barrier. So your thoughts there?
Yeah, I think that's absolutely right. I think it comes down to that communication, having open dialogue. I also think if you're able to articulate the rationale behind why to consolidate, right? Potentially, whether that is in here's what this means to you. I'm not able to effectively add more technologies because we have an existing portfolio of technologies that we need to support. Having that conversation, the art of the dialogue with the individuals that are affected, I think is really important. I also think it's important to understand, is this truly a change fatigue issue? Meaning, I just don't want to change because of introducing change and I have the existing muscle memory? Or is it because the tool that you're consolidating to doesn't have the workflow that they need, isn't meeting a critical need? And that's a worthwhile conversation to have. That is something that you can't overlook because that is functionality that won't exist in the other tool. So to me, again, I think if anything from this conversation, the core of this conversation is around culture and communication. So keeping that dialogue open, understanding why in terms of from a rationalization perspective, what are the challenges? And I think some of it also comes down to persistence. So because we have so many other, again, new technologies that are coming in, oftentimes it's hard for us to focus on how do we decommission some of these other tools. So having the organizational fortitude and having that sense of persistence to make sure that that is a priority for us, I think is something that, again, goes back to that culture and that communication concepts.
All right, very good. Back to governance a little bit in light of the discussion we were having. When we talk about application rationalization, we talk about the idea of consolidating and removing some tools that are redundant. We get into these conversation with clinicians that you alluded to, which is, um, and sometimes people use figures like 80/20, meaning if we have 80% of what you're looking for, then let's consolidate because it's better for the organization. It may be better for integration or whatnot or cost. Um, so you give up a little bit of your bells and whistles. Now, usually, if you're having IT discuss this with operations, IT per se is not going to be able to make the judgment of 80%. They don't know the workflows that deeply to the point that, you know what, you can't have IT saying, you know what, we think this is good enough for you. Not going to work, right? So you need some sort of governance where that's representative of operations that takes a look at that and is able to say, okay, 87%, yes, we're willing to consolidate on the other tool, or no, we're the clinicians and we don't feel like this tool is as good as the one we have, and the costs will be too much. So, like, it's that gray area, it's the nuances, the straw men people set up are easy, right? Cases. Oh, well, then you do this, or then you do that, but it's that gray area in the middle where things get pretty interesting. What are your thoughts there?
Yeah, I've heard of the 80-20 rule. I've been burned by the 80-20 rule because oftentimes the 20%, depending on what we're talking about, can be the most critical 20%,
Right.
right? And so the 80-20 concept, while in theory sounds really good, it may not necessarily always pan out. So you mentioned governance, but I think, when governance is done well, it's not really about governing, it's about collaborating and it's about having the conversation. And
Uh-huh.
so really understanding what that 20% is. And again, is that 20% the critical component? So it's not something that you can throw up on a spreadsheet that says, here are the 100 different capabilities that we have from application A, and here are the 100 different capabilities from application B. And you know what? These 80 things make sense, these 20 things don't. Then you have to have that conversation and that dialogue to say, we aren't, I'm seeing the 20, that's a delta. Is this really truly 20% for you? Or is that really more like 50% in terms of your overarching workflow? So it goes back to having that conversation. It should never be heavy handed. It should never be, this is, we're governing this. It's more of that part of the dialogue again and having that conversation. But I think it comes down to having a rational discussion, but having something documented that says, here are the features, functions, here are the
Right.
workflows, and being able to use that as a prompt to have that discussion. I find it a lot easier to have unemotional conversations when you have things that are documented
Uh-huh.
and you're able to talk through them. It's not going
Yeah.
to be perfect, but you have something that you can reflect on versus just saying, this is application A, application B, because you inevitably will have sides that'll come up
Yeah.
as a result of it.
Very good, very good. All right, a couple more things here. I'm gonna let you go, not take too much of your more of your time, but we talked about how difficult it can be to decommission and to remove an application, which is all the more reason that we should now have an extremely high bar for getting new applications in. You mentioned the portfolio, check the portfolio. So we really want to make sure that's a tight process, that there's a high bar for bringing in new tools and technologies, especially those that are outside of our core suite, whatever that may be, because that's a lot easier than sort of pulling a tool out of the hands of users, right? So what are your thoughts there? Do you believe that should be a pretty high bar?
I don't know if it should be a high bar because we also want to be able to innovate and trial and test new things. So I think it comes back to a balance. I think we want a high bar for those tools that we want to roll out across an enterprise. Absolutely. We need to make sure it works. We need to make sure it's not redundant, but we also want to create opportunities for our clinicians to try different things. And the discipline there is to be able to say, we're trying something, it's a pilot, we need to be able to decommission a pilot. And so decommissioning isn't necessarily just for applications that we are rolling out that have been implemented across the enterprise. We can also decommission pilots, and we need
Yeah,
to be able to have those strong conversations with our vendors, because usually vendors come away thinking, oh, we have a pilot at your organization, so the next logical step is you're going to roll it out
right,
across the enterprise. Nope, I think we need to have that conversation that says, we've tried it, there's certain things we like about it, there's certain things we don't like about it, here are the things we don't like about it before we might even consider rolling this out from an implementation standpoint. And when we do, what are we going to decommission as a result that perhaps already exists in our portfolio? So it's a balance, Anthony. I think we don't want to make it so difficult that the organization can't try new tools, but at the same time, we don't want to necessarily scale things that are redundant.
Brilliant. Pilot discipline is a good term for it, right? Have
Yep,
discipline with your pilots.
exactly.
All right, Edwina, just one last question, gonna let you go. So the sticky concept that you're working on, that you're implementing, um, if you were to give people an overview of the program in terms of how they could do something similar, how would you just briefly summarize, like, here's what we're trying to do, here's maybe how you could try something similar?
Yeah, it's really a mindset. It's not necessarily a framework. It's about asking those questions.
Yeah,
So you can ask it at, the incremental change level when you're looking at whether you turn on a feature in an upgrade or not. You can pause and ask that question during large implementations to say, is this seamless? Is this integrated? Is this going to give us the yield that we need to think about? So it's really about how do we create a framework or a mindset that enables us to ask those questions rather easily. And then I think to our discussion, it also has to be done at the other side when we're decommissioning. Is it still sticky? Is it
right,
still giving us the yield that we want? Is it
yeah.
still integrated, or has the workflow changed where it's no longer integrated into what clinicians are actually doing today? So I think it's bookending it from both angles, not just when we implement solutions, but also on the back end when we can potentially decommission.
Edwina, that was wonderful. That was a beautiful chat. I enjoyed that very much. You made some excellent points that I have not heard before, opening my mind. So thank you very much. I appreciate it. And I hope we can reach out to you again down the road and catch up.
That'd be great. Thank you, Anthony.
Have a great day.
You too.